Everybody. I do just want to remind everybody that we are recording, and usually my little joke is that don't say anything that you wouldn't tell your mother, but seeing as my mother is actually here today, I have to live by that rule anyway. So welcome, Mom. Hi, Mom. And thank you so much for joining us on this beautiful New England autumn morning for the first in what I know will be a very meaningful speaker series. I'd like to, in particular, welcome House Representative Denise Garlick, if she does indeed join us. Denise has been a big supporter of the hospital and is passionate about bringing services to the local community. In addition, we have Dr. Mehta, who is the co-director of the BID Medical Center and BID Needham BreastCare Center and Chief of Breast Imaging. And she is joining us as she can while she's working at the same time, multitasking.
Good morning, everybody.
Good morning. This series is really derived from the original in-person speaker series that was hosted by BID Needham for many years. And then in addition, the virtual leadership through COVID, mostly board and advisor speaker series that I moderated before the summer. What we hope to achieve with this speaker series is to educate ourselves about important topics, to discuss and even debate relevant questions, and finally, to continue to provide connection through virtual and eventually in-person events. Before I introduce our speaker, I'll ask John Fogarty, President of BID Needham, to give us a brief update.
Thanks, Sam, and good morning, everybody. Good to see everybody on the call. Let me put my glasses on so I can actually really see everybody on the call. I'll give a brief update on the hospital, but before I do, just a couple of comments. I had kind of an interesting serendipitous moment when I was walking into the office today because a month or two ago, Sam Sherman and her team arranged we have lots of great pictures from events over the years that we've done at the hospital. And because my outer office is kind of barren, they thought it would be a good idea to spruce it up a little bit with some pictures from some of those events. And one of them is actually one of the best event pictures we have, and it's the ribbon cutting of the breast center. Partly because I'm off to the side and Dr. Mehta is in the middle of it, and she's like the most photogenic person that I know. But it's a great cross section of the team, and I just noticed that at the bottom of it, the date on the ribbon cutting is October 13th, 2016. So we're 4 years and 1 day old in the breast center. So it's that's a project that we've been really proud of, that has been something that was, I think from the very first day I started here 10 years ago, that the primary care doctors were saying, John, you really need to do something in a more comprehensive breast center. So it took us a while to get there, but it was great, and just sort of interesting that we have this session basically on the 4-year anniversary of the center, which really wouldn't have helped or happened without help from the community and philanthropic supporters who were key in making that happen. And I'll leave it to you, Sam Berman, to do the introductions, but I do want to say we're really happy to have Sonali Pandya here, not just as our speaker, but just as the new leader of the breast center. It was a recruitment that, like everything else, was sort of hobbled by COVID and drug along because of the impacts. But she's been here a few months now, and it's been great. And I know Tejas will speak to this maybe later, but also, although she's not on the call, Vandana Diliani is our new director of community breast imaging, and so two really great emerging leaders that we're happy to have on the team. I think it's kind of an understatement to say it's been a momentous year at the hospital. I really can't think of anything that in my 30+ year career that compares to it. So we started the year really kind of moving along business as usual. And then around the middle of March, we really started to see the incidence of the COVID-19 pandemic and, essentially shut the hospital down. Inpatient, outpatient care in particular was under the governor's order really put on hold. Inpatient care continued to be busy. Almost 70% of our patients at Needham at one point in time, April, May, 70% of our patients were COVID positive. So with the PPE challenges and the way that we had to do things differently, it was just an incredible effort locally and at a system level. I think it really put the systemness of Beth Israel Lahey Health on a fast track, because we had to form an incident command center at the system level, where a couple of times a week, discussions about how is our PPE supply? Where are we going to get ventilators? Who's short on ventilators? How does the transfer system work? Do we need to deploy anesthesiologists or critical care doctors to this hospital or that hospital? And, you can't go through something like that without being a stronger system at the end of it. And that certainly happened here and throughout the system. I think locally, the staff, particularly the frontline staff, our nurses, our physicians, but really everybody, nothing short of courageous, people who risked infection every day and continuing to come in and taking care of patients. It was just amazing to see how people really stepped up. And also how the community stepped up with the Healthcare Heroes Fund. I think you've certainly heard a lot about it. The hospital, I think Needham was really out on the forefront with this in raising over $500,000 in gifts and in-kind gifts for our frontline staff. Number of people may not have gotten through things on the home front without the support of the Healthcare Heroes Fund for things like groceries, childcare, transportation, things that some of us take for granted. But if you're a frontline worker and your spouse is furloughed or loses their job, there are people who really needed that to get through. And just an amazing kind of a triumphant effort by many, many people in the community, and some of you on this Zoom. So we feel like we're on the other side of it. I'd say that with crossed fingers, because none of us really know what the fall and winter will bring. But we're down to from having 60 or 70% of our inpatients COVID positive to having 1 or 2% of our patients being COVID positive. We are fortunate that, again, knock on wood, that we did not have large numbers of employees that were affected by the virus. We had some, but not large numbers. We have a very watchful eye out now, because we are starting to see an uptick in the community of COVID cases. And I say an uptick, not a surge. But there have been outbreaks that you've all read about in the paper and among hospital employees at other hospitals with the virus. So we have to be very conscious of that as well. It has not affected us here yet. And we're preaching social distancing and masking. And you don't have to put your guard down very far to have a problem. It's a highly contagious disease. But we had some pretty severe financial difficulties in the spring, as did every hospital in the country. And through a combination of federal stimulus funds and our recovery after June, when the governor really started to lift the ban on elective surgery and outpatient care, we really started to regain our footing. In the middle of that, we had a Joint Commission accreditation survey, which sort of, that's one of those, when it rains, it pours types of thing. We got through the survey well. And, again, just the testament to the focus and the stick-to-itiveness of our staff and managers who, very easily could have said, you know what, I'm throwing the towel in here. I've just gotten through a pandemic. I'm not up for a Joint Commission survey, but nobody did that. And they did a great job. So we thought, okay, let's take a deep breath. And then at the end of June, as many of you may have heard, Norwood Hospital experienced a very severe flash flood that effectively shut down the hospital. So this is a situation where a hospital that was fully functioning, 40,000 emergency room visits a year, 215 beds, 60 psych beds, was fully functioning on June 30th and completely shuttered by July 2nd. And I've never, ever seen anything like that. This is from a 20-minute rainstorm that flooded the first 2 floors of the hospital, shorted out their electrical infrastructure, ruined their pharmacy, damaged their power plant, and then with the subsequent moisture and mold that came with it, really has rendered the hospital inoperable. So because of geography and the way that ambulance runs go, the bulk of those patients have come to Needham. Not all, but the bulk have come to Needham. So I would say times where I feel like we had 2 pandemics in 1 year, because the impact to Needham of the Norwood closure has been easily as significant as the pandemic, perhaps not on a societal level, but on a impact to our frontline caregivers, easily as significant, where our emergency department volume went up 25% overnight. Our inpatient activity, in some weeks is 35 or 40% higher than it was a year ago. So obviously, no advanced warning, no preparation, and coming on the heels of a pandemic where no one was interviewing, so we weren't recruiting. We have had to scramble as though our lives depended on it to get nurses and other staff to keep up. We're seeing beams of daylight now, but it was a rough end to the summer and early fall. So that hospital is probably closed for a number of years. So I believe their hope is that they'll get a standalone emergency room running sometime in the first half of 21. But the hospital, we're hearing, could very well be a teardown. So the hospital proper is unlikely to be functioning for anywhere between 2 to 4 years. So just really, again, an amazing meeting of the challenge by our nurses and staff and medical staff to respond to the challenge. So we've gone from a period of the depths of the pandemic when we were wondering if people were ever going to come back to hospitals and would we be a shell of our former selves, to wondering what are we going to do with all these patients flooding into this place. So, but I'd say the organization has adapted pretty well. It's been tough, again, mostly on frontline caregivers, but I think people have really stepped up impressively. So a lot of what we do going forward in 21 will be formed by our experiences this year. You will see a more significant commitment to behavioral health at BID Needham in the past, where I would say a year ago, we were certainly doing our part, but somewhat due to the community that we're in and geography, I'd say we were maybe more of a bit player than others. We're not a bit player anymore. So our behavioral health volume in the emergency room has quadrupled since the Norwood closure. So we have had to significantly up our game. We have some plans with our intensive care unit to really upgrade our intensivist critical care staffing for two reasons. One, if there is a resurgence of the pandemic in the winter, we need to have the A team on site on a more significant basis in the ICU. And secondly, because in our evolution as a community hospital to be more of a community medical center, we really need to limit the number of patients that we're shipping into the medical center or into Boston that need more sophisticated intensive care. So that's all among the things that we're working on going into this year, but really just proud that not just the employees of the hospital, but the community that supports us has stepped up to the challenge and met the challenge of 2020, which a lot of people say it's a year they'd like to forget. And I will say there's days when I feel the same way, but there's days where I think, no, it's really, it's a year to remember because we were tested and we met the test. And that's something I think is in some respects worth savoring. So that is sort of year in review and a brief view into 2021, but really glad to join the meeting and participate in the discussion. So Sam, I will turn it back over to you.
Thank you very much, John. You know, I'm every time you do one of these updates, I'm just really struck by how beautifully, and I would agree courageously, pretty much everybody at the hospital has responded to a very unpredictable year and really demonstrating leadership at all levels. And so obviously thank you for your leadership, but also understand that it took the whole organization to respond in the way that it has to all these different challenges over the last 9 months. So thank you. I know there may be questions for John, and maybe we can hold those to the end if we end up having time, so people could put those into the chat, or we could get back to those. So it is my pleasure now to introduce our speaker, Dr. Pandya. And as mentioned, she joined us a number of months ago from the Women and Infants Hospital. She is the co-director of the BreastCare Center in BID Needham and also a breast surgeon. Throughout her career as a surgeon, Dr. Pandya has been dedicated to helping those afflicted by breast cancer. She brings her impeccable clinical and surgical pedigree, and as we will see, her leadership to her position as the co-director of the BreastCare Center in BID Needham. Along with the Link Cancer Center, the care provided in the BreastCare Center, to me, epitomizes precisely BID Needham's raison d'etre, to offer the clinical quality of an academic teaching hospital in the comfort and convenience of your own backyard. I've experienced the difference through my mother and my sister's cancer care. Dr. Pandya will be joined, I believe, at the end of her presentation by Dr. Bodeo Downey, who is the medical director of the Link Cancer Center in Needham and the chief of hematology and oncology at BID Needham, and also led the team that cared for my sister recently. So with that, I would like to introduce our speaker and have you take that away. Thank you.
Samantha and everyone, thank you so much for the wonderful introduction and allowing me the opportunity to speak with you all. So Hillary has the presentation that she will share the screen. Okay, can go to the next slide. So I wanted to take the time to talk about the breast care clinic at the BreastCare Center at BID Needham. The breast care clinic is set up with the following team members. As you know, I'm the co-director. I am also assisted with Dr. Ted James, who's the section chief and co-director at BIDMC. On staff, we also have 3 nurse practitioners, Emily Howland, Zinat, and Kathleen. Our team also consists of a nurse navigator who joined our team last year. We have a practice manager, a medical assistant, and 2 administrative assistants. Next slide. In regards to introduction and about me, I was originally, or I should say, I was born in India and moved to Florida in 1991. I was raised in Florida, and then following that, my studies were in medical school in Grenada at St. George's University, and that was followed by a residency at Albany Medical Center in upstate New York. I completed that in 2009. And subsequently thereafter, I went to Women and Infants at Brown University for my breast surgical oncology fellowship. I completed that in 2010. Next slide. Following that, I went back to my home state of South Florida and practiced there from 2010 to 2015. I started a multidisciplinary breast tumor board at the hospital in West Palm Beach. Additionally, we also implemented breast-specific protocols for diagnostic evaluation and specifically changed the protocol in the pathology department. Following that, in 2015, I was recruited back at Women and Infants and practiced at my former alma mater. At Women and Infants, we had a robust practice. It was a tertiary level care breast center, and we treated approximately 450 to 500 women with breast cancer diagnosis. I have a strong interest or a desire to teach. That was one of the big reasons I came back to the New England area. Additionally, I also have an interest in patient outcome-centered research, and being at Women and Infants allowed me the opportunity to participate in multiple trials. I was a site PI for a multi-center study started at Yale, which evaluated the value of shaved margins. Additionally, I was able to be promoted to assistant professor of surgery at Brown University Medical School. Following that, this wonderful opportunity at BID Needham came up, and I decided to pursue this opportunity, given that it would allow me to be a leader and come back to my roots of practicing in a community-based hospital. And subsequently, I was lucky enough to be recruited here, and I joined the program in August of 2020. As a whole, my clinical interests are management of benign and malignant breast conditions. I also have an interest in management of high-risk patients, as well as patients with high-risk breast lesions, specifically women who have had biopsies that show atypical hyperplasia, lobular hyperplasia, papillomas, or radial scar. And I have an interest in following our patients longitudinally, specifically in their survivorship. Next slide. In regards to my research interests, I also have an interest in looking at research related to young women with breast cancer. While at Women and Infants, we had initiated 2 studies that I was a PI for. One was looking at barriers to fertility preservation in young women with breast cancer. And the other study that I had initiated right before I left, it was specifically designed to look at psychosocial impact of breast cancer diagnosis, specifically on younger women under the age of 40. And it was designed to identify any interventions that we could utilize specifically in regards to any socioeconomic factors. As far as my involvement in the medical education at Harvard Medical School, since being here for the past 2 months, I have been able to become a faculty in the practice of medicine curriculum. I'm a faculty of the Developing Physician course that's provided to first-year medical school students. Additionally, I'm also faculty to teach clinical breast examination. In regards to the surgical management and treatment, as we know that 70% of the times we do strive to recommend breast conserving surgery to our women who have been diagnosed with breast cancer. Within that realm, one of the areas that I'm particularly proud of and happy that myself and Dr. James provide at our breast center are the option of hidden scar surgery, and my subsequent slide discusses that. Additionally, there has been data and evidence supporting utilization of what we call oncoplastic reconstruction at the time of breast conserving surgery. This is a technique that allows a woman to undergo the surgery for removal of the breast cancer. And at the same time, it gives them the opportunity to have a cosmetic surgery that gives them a better contour and shape, and also allows them to have surgery of the opposite breast for symmetry. The other surgical treatment and approaches that's my specialty as well is skin and nipple sparing mastectomy. Next. In terms of hidden scar surgery, this is a very important aspect of the surgery because as we know that scars can be a lifelong reminder of what a woman has gone through in regards to the breast cancer surgery. It may be empowering to some women, though to some women it can be a lifelong reminder of what they have been through, especially if the surgery has led to any cosmetic changes or changes that alter in terms of how they have a general sense of well-being and sensuality. So given that, we have strived or we do aim to hide the incision in the following areas. One is the periareolar incision, which is an incision in the pigmented part of the nipple. The other incision is underneath the breast, as we call inframammary incision. And this is also utilized in nipple-sparing mastectomy. And the third hidden scar area is the axillary region. The goal is to provide good cosmetic outcome because we do know that as a whole, any surgical scarring or any changes to the shape or size of the breast can lead to significant impact on psychosocial and emotional recovery and have a significant impact on a woman's quality of life. One of the approaches that I utilize in the operating room is utilization of what we call lighted retractors, and it does allow me to get a good visualization to be able to perform the hidden scar surgery. And at BID Needham, the surgical team has been extremely helpful in ensuring that I was able to get these retractors in a matter of 1 to 2 weeks. Next. The other significant technique that BID Needham has been one of the first hospitals on board is called Savvy Scout. So in about a decade ago, or even more than that, when I started my general practice, we usually wires lumpectomy. But we have found over time that can be a very cumbersome process for the patient. The patients are in the hospital for a much longer period.
Sonali, sorry to interrupt. I'm not sure if I'm the only one. I'm just having trouble hearing you.
Yeah, I don't know if the microphone is somehow, it was great until
when?
until one slide ago.
Oh, okay.
Yeah. We're just getting a little feedback and you're just not quite clear. And I want to make sure I get everything you say.
How about now? Is it better?
That's better.
Okay.
Yes.
That's better?
Yes.
Okay. Hillary, do you want to go back a slide, please?
Thank you.
One more, just to the hidden scar slide. Can I just restart that discussion?
I think we heard you all the way until the very end of that slide. So I think you can go on to the next slide.
Okay, thank you so much.
Thank you.
Okay, so I wanted to talk about Savvy Scout system. This is a system we have at BID Needham, which has allowed us to move away from utilizing wires at the time of lumpectomy. This has also allowed us to take a smaller amount of breast tissue, which, as we could imagine, could lead to a better cosmetic outcome. Studies thus far has supported that using this technique has not adversely impacted the ability to clear the margins. And in fact, thus far, the studies have supported that it has shown a better cosmetic outcome in at least a short term of follow-up. The other technology we also have at BID Needham is we have a Trident or a specimen radiograph machine. So if you look at the bottom of the screen, the very last picture, it actually shows a picture of tissue that's removed at the time of the lumpectomy. And in the middle, you see a clip and the Savvy Scout device. By having this technology, the surgeon, myself and Dr. James and the other breast surgeons can immediately, at minimum, assess what the margins would look like. And based on this picture, if needed, we can take additional tissue and hence reduce the need for more surgery. Where prior to having this technology, the specimen used to go down to radiology department, and then we would place clips at the edges, but it was still really hard to visualize whether this is a superior or the top margin or the lateral margin. But having this technique in the operating room, decreases need for more surgery, also has shortened the amount of time the patients are under anesthesia and has allowed us to do a quick analysis of the margins. And in terms of being able to do this at BID Needham is an incredible opportunity that we provide to our patients. Lastly, one of the very striking things that I noticed in about a decade of my practice is that BID Needham has a dedicated breast team, which I was very impressed upon learning that we have that. And the great thing about that is that patients, or rather the surgeon, is always working with the same group of nurses and circulating team, and that allows a much better flow of care, and overall it definitely facilitates the surgical time and care to the patients. Next slide. So let's talk about the multidisciplinary clinic. This opportunity for our patients to meet with the surgeon, the breast medical oncologist, and radiation oncologist, along with the rest of the team, has been available at BID Needham for some time. During the pandemic, we had temporarily stopped that, and it was restarted on October 5th. We had 2 patients at our first multidisciplinary clinic, and the plan moving forward is to have this at the first and third Monday of each month. And it is in very cohesive collaboration with our Lane Cancer Center, with Dr. Bodio Downey as our medical oncologist, Dr. Stuart Berman as our radiation oncologist. We recently added genetics to join the MDC as of October 5th. We have physical therapists, nutrition, social work, breast pathologists led by Dr. Lauren Berry, and breast radiology team led by Dr. Dialani. We also added a nurse navigator to our team as of 2019, Patricia Byrne. She is in her nurse navigator role at the BreastCare Clinic. The importance of a nurse navigator is the following. They are oncology specific. They provide individualized assistance to our patients, family, and other members of the care team. Studies have shown that having a dedicated nurse navigator does lead to reduction of barriers to getting appointments with specialists. It also allows the patient to have care in a timely fashion. And more importantly, it allows the patient to have a longitudinal care throughout all phases of their treatment. Let's talk about, what's on the horizon. The goal with me being here full time and working with the breast radiology and the rest of our team is to grow the program, continue to serve our community and our local community. So the following things are on the horizon at the BreastCare Center. One is the addition of a stereotactic biopsy equipment. What we found that there are anywhere between 7 to 9 patients or women per month who are recommended to undergo stereotactic biopsy. Fortunately, our team facilitates this with the BIDMC Boston team, and we do ensure that there's retention of care within our program. But having this opportunity at our hospital will allow the patients to have that biopsy at BID Needham. The other program that we're looking to add to our BID BreastCare Center is the risk assessment program. So I wanted to spend some time and talk about that. So what is a risk assessment program? It is an opportunity for a woman who comes to the BreastCare Center to complete an online questionnaire that allows the woman to be able to assess, or us to assess, what the lifetime risk for developing breast cancer is. And this gives us the opportunity to identify a subset of women that would actually benefit from not only having a mammogram, but also having an annual MRI because they have an elevated lifetime risk for developing breast cancer. Additionally, this questionnaire will also allow us to identify women who would benefit from meeting with a genetic counselor for genetic testing, specifically if they have a family history of breast and ovarian cancer and other cancers. It allows us to identify those patients. Also, what it does, it allows us to communicate this information with the patients and their primary care physicians. So the radiologist is able to look at the lifetime risk that's calculated by this program, and then that's incorporated in their report, and then that is communicated with the physician and the patient, hence allowing us to provide an individualized and a personalized approach to screening The other opportunity we imagine that or envision this would have is to identify the group of women who are high risk. And then that would mean that those patients or those women would benefit from meeting with a breast surgeon or a nurse practitioner who provides breast care. And it's important because this would be an opportunity to talk about risk reduction strategies, such as importance of diet, lifestyle, and also ability to talk about what we call chemo prevention or endocrine risk reduction with tamoxifen or anti-estrogen medication to reduce lifetime risk for breast cancer. So we envision addition of this program to allow us to identify a subset of women who otherwise are missing the opportunity to have high-risk screening and discussion for genetic testing. The other opportunities on the horizon are to expand our diagnostic access to 5 days a week. And lastly, beyond that, we would also envision addition of MRI-guided biopsy at BID Needham. So these are all the opportunities for the growth of our program. Next slide. So lastly, in regards to the other very important point of all of this is access to care. We all strive to make sure our new diagnosis patients are seen in a timely fashion. And at this time, we're able to ensure and certainly guarantee that our patients are seen no later than 48 hours from the time of diagnosis. So thank you, everyone, for allowing me to speak about our program.
Thank you very much, Dr. Pandya. That was really helpful to understand. I thought I knew more than I did about everything that's going on out there. And what I really enjoyed understanding was, I was first of all struck by the conversation about the entire person, right? The entire patient, right? Not only the surgical intricacies and obviously the physical care that you do so well, but also understanding the recovery, understanding the psychological effects and so forth. And that's so important. And I also am always interested in new technological advancements because it seems like that's happening all the time. So very much appreciate that. The other thing I learned too was the benefit of the dedicated breast team in terms of the nursing care, both in the operating room and outside the operating room. So I was definitely struck by that. So I think that what I'd like to do is first of all, say good morning to Denise Garlick. Denise, we very much appreciate your participation and your ongoing support of the hospital and your dedication to making sure that we continue to provide excellent service to your constituents. So thank you so much for joining us.
My pleasure.
And then I'd also like to officially welcome Dr. Bodeo Downey, who I believe is going to also be taking questions. So Sam Sherman, how would we like to do questions this morning? Would people like to either, we have a big enough group that maybe we do it using the raise hand, or people can just wave?
I think people can wave, or you can type them into chat. Either way, and we'll keep an eye on the chat screen. But I think for now, to kick it off, if anybody just wants to raise their hand if they have a question, either for John or one of our physicians. Looking through all the.
I just say, Sonali,
Okay,
I thought that was an excellent presentation.
Yeah, great job, Sonali. So I feel like as the only man on the call, I'm obligated to ask a question for some reason. Sonali, I would just be interested, your observations being out in the community, the Needham community for a couple of months, any particular needs or disease patterns or anything you're seeing in this community that you think might be unique, or something that may have been surprise to you, or anything out of the ordinary?
So I have to say with the fact that we just we're in the middle of a pandemic, and there has definitely been a delay in screening and certainly a delay in diagnostic, and that's purely because of the time that we're in the pandemic. So I have to say, at least in the short time I've been here, And we've also noticed this at BIDMC during our tumor board discussion, that there has been an increased locally advanced breast cancer that we're seeing. And I don't think that's because, women do not have access to care. I think it's right now because of the pandemic. I think women who may have put off their mammogram perhaps by 6 months, then added another 6 months or 9 months to getting the mammogram. So that's one thing I'm seeing, though I think that's likely, as we know, due to the pandemic. As a whole, though, I think we're doing a really great job in educating our women and making sure that they do undergo mammogram annually. And I'm definitely seeing more of that in Needham as a whole. Generally speaking, at least in our follow-up clinics, patients do get mammography every year. And, we know that there's up to 30% of women who outside of this community actually do not even undergo routine screening mammogram. So I think we're doing a fantastic job in educating and providing access.
Thank you.
Can I just say, I'm going to chime in
Yeah.
and echo that comment of please, 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 if you're due for your mammogram, tell your friends to get the mammogram and not delay because of fear of COVID. It's a very safe environment we've created. It's safer than any other place that you're going to go, whether it's to the coffee shop, to dinner, to the grocery store. So we are seeing people delay, and it's unfortunate. So please spread the word. Thanks.
Thank you. I am seeing questions come up, so I'd love to get to those, but I realize I cut you off, Denise. Did you want to say a few words this morning?
No. Can you hear me? No, you didn't cut me off at all. So I'm very glad to be here. Like John, my question was around the communication in our community and how I could be helpful with that. So I look forward to this whole discussion. And I am wondering, though, I have to tell you, my friends, how it is we only have one man on the call. So we also have to work on that.
We have two, actually. Someone with Judy Kaufman. There's another.
Carol, Judy's mom. Hi.
Hi.
I just wanted to say that I was very happy to hear that you have instigated a genetic testing program. Judy and I have been tested in Boston. I've been tested over the years 3 times. And before my husband passed away last year, he was tested. And we were happy to find that everything was negative. And it wasn't because of me, that whatever my children might have had, and we have had cancers going through our kids. It's not my fault. It kind of gives you a safe feeling. So I'm happy to hear that you're doing this.
I try to blame her for everything. Yes, I can't on this one.
In the cancer center in Needham at the Link Cancer Center, we had pre-pandemic been able to have genetic counseling here on a weekly basis. And now things are different a little bit in the pandemic, but that is something that we hope to be able to bring back in person sometime soon. But right now they're still providing that, but virtually. And I think you're right, Carol. I think it's a huge part of oncology care is being able to offer that genetic testing to folks. I think not only does it take the worry that you pass something on to your family, but also if you do find something in terms of some sort of a gene or some sort of a syndrome in somebody, it allows you to be proactive, which I think is really kind of the name of the game in cancer care. You know, if you identify some sort of a syndrome, you might know that, okay, this person needs colonoscopies more regularly or endoscopies or dermatology checks, or we should do something to try to monitor from a pancreatic cancer standpoint. So I love the idea that we can bring genetic counseling out to the community and really put people in a proactive situation as opposed to being reactive.
Thank you. Yes. Janet, you had a couple questions up on the chat. Would you like to pose those to our panel of doctors? Oh, I think we have you on mute. Oh, there we go.
Did it come? My dog keeps barking, so I will try and squeeze the question in without her disrupting everything. The first question I had around the software that you talked about, the patient questionnaire to determine what their risk level is. How hard is that to implement?
Okay, so currently we are looking at, or we've looked at 3 different platforms, and of those, there are 2 that we really like, and we want to investigate them further. So in regards to actual implementation, is it goes through the whole process of identifying the one that fits best for our program, and certainly looking at the cost benefit analysis, but overall the return of investment. I think we look at the big picture that it will, as a whole, allow us to identify the patients that need more closer follow-up and surveillance. In regards to the implementation, it would require the patients to have access to going online and filling out this questionnaire. If they cannot do it, then they can come to the breast center and use an iPad to be able to fill out the questionnaire. But beyond that, it then actually just generates a report that the radiologist can look at and put it into their actual transcription. So I don't think that we'll have a challenge implementing and continuing it. It's just all of the processes before that to allow us to get the appropriate software and getting it approved through the departments.
That's great. My other question was around mental health support for women after they have surgery. I have a couple of friends that have gone through it and have said, like, I don't feel like a woman anymore. And what kind of resources are there from a mental health standpoint?
So Dr. Downey can also, comment on this, but we have a social worker who is part of the Lung Cancer Center, and she meets with all of our patients who are newly diagnosed with breast cancer. And depending on their ongoing needs, she provides ongoing support. So that's an opportunity. The other opportunity would be participating in a support group where, women will have opportunity to talk and share their experience with other women who've gone through similar experiences. So having that full-time support and access to social work is how we envision that we would make sure we identify any ongoing issues and make the appropriate referral. Beyond that, if there is an area that requires having the patient see a psychiatrist or psychologist, then we'll ensure that we facilitate that referral.
Thank you, and thank you for the question, Jan. Oh, sorry, Dr. Downey, did you have?
Sorry, I was just going to say, to piggyback on what Dr. Pandya had said, there's also, there are 2 psychiatrists at BIDMC right now who kind of specialize in the care of patients with oncologic issues. So it's nice. Our social worker kind of has good access right into them. And again, now that's been something that probably hasn't been as frequently utilized in the past, sometimes because that's sometimes it's challenging to get people to go to Boston for that appointment. But actually, one of the things that I think maybe will be a benefit, I'm trying to see the silver lining in the pandemic, is that turning these things into telemed visits and virtual visits has expanded access actually in some ways. So the psychiatric option, like the oncologic psychiatric options, I guess, to see if we need medications to help folks in that regard has been incredibly beneficial.
I would also like to add one more thing. About 32 years ago, Hester Hill, who was head of social work at the Beth Israel and the Cancer Center, she and several other people started a program called Patient to Patient, Heart to Heart, which now no longer exists. It included volunteers who had been treated with all kinds of cancer. And we would get together as a group, and she would assign her patients to us according to what cancers they have had and we have had. And we would originally start talking on the phone and very often met. And the program went on until a couple of years ago and retired. And the volunteers in the cancer center there were just unbelievable. And it's just a program that is so helpful to the patients to be able to talk with someone who has gone through this. Thank you.
Thank you so much for sharing that.
Carol, sorry. Carol, did that program end only because Hester retired?
No, I think it was dwindling.
Oh.
And it was hard to get patients. It was so hard to become a volunteer at the BI. We had to go
Yeah.
through so many months of stuff in order to volunteer. I did not when I started 32, 34 years ago. It was very, but then it became so difficult that I think the program just kind of dwindled. And now, of course, there hasn't been anything going on there as far as volunteers are concerned.
Right.
But the fact that we start with the phone calls and now there's such a thing as FaceTime and Zoom, that if people need that visual contact connection, it's available now, which it wasn't back then.
Yeah, that sounds like a tremendous resource. And you might, I can envision even some of my own patients who would maybe benefit from that, maybe even more so than a support group per se. So I'm very interested in that. I know the volunteer opportunities on site are challenging right now, but like Judy said, right now there's so much that's being done virtually on Zoom or FaceTime. I wonder if that's something that we could bring up, and maybe now's the perfect time for that, because I feel like the social connections are something that is lacking, particularly right now in oncology care. You know, if you've had your volunteer time, you would know that when people were here getting their chemo, we tried to, I don't want to say make it fun, but there were volunteers, people would stop by, you'd bring books, there'd be lunches, and all of that is gone. A lot of patients now, when they're coming in for their chemo, are here by themselves because we're trying to limit traffic and people through to limit the COVID exposure. So to be able to have almost like that buddy as they went through treatment might be a really good time to reinvigorate that program.
Yeah, I would absolutely agree. It's the sort of flip side of virtual connection. It also means that you can get people physically, you know, not physically together, but virtually together that couldn't in the past. And so, yeah, I think that sounds terrific. I know we're running a little bit low on time. I had one question specifically for Dr. Downey on, from a patient's perspective, the sort of interconnection between the BreastCare Center and the Lung Cancer Center, and how that looks in terms of the patient's experience, and also how that might relate to any care that's still required downtown.
That's a great question. I think with the reinstitution of the multidisciplinary care of the clinics there, that hopefully that transition will be more seamless. We try to see the patients together on site in the multidisciplinary clinic, right? Radiation, breast oncology, and surgical oncology. But what we also want to prioritize is that we'll be available for any patients, as Dr. Pandya had said, that pop up with new diagnoses. If it seems that things like chemotherapy before surgery would be of benefit, we would like to see those patients right off the bat. And then I think we try to stay, myself and Dr. DeRose, who's the other medical oncologist here in the Cancer Center, try to stay on top of what clinical trials are available downtown, so that if it seems that this patient, because of whatever the characteristics of the disease are, or kind of specifics about the case, seems like that person would benefit from a clinical trial, then we'll make sure that we get them downtown. The nice part about the staff that are here in the Cancer Center, in the Link Cancer Center, are that we are all credentialed, like we're part of the same division. Basically, we're part of the Hem/Onc division at BIDMC. So they joke around and call us just the 11th floor of the Shapiro building, which is, you know, they only goes to 10 floors. So we're the 11th one. We're just kind of an extension. And you know, that ability to be part of that division allows for kind of seamless transfer of care. If we think that there is somebody that would benefit from something that's available downtown that's not here, it's a quick email or a page to one of our colleagues, and we just say, hey, can you please see this patient for me? I think they need X, Y, or Z, and we don't have that here.
Right. And just to piggyback on that, from surgical standpoint, the 2 times that I envision patients would go to the main center are for the following: if they undergo a mastectomy and they prefer to have a deep flap, which is utilizing your own tissue to reconstruct. And this particular surgical technique and the technology that we need to do this procedure is available at the main center. The other time is if our patients undergo more extensive lymph node surgery, what we call an axillary dissection. And then, you know, the goal of that procedure is to clearly take out the lymph nodes that are abnormal, but in doing so, it also increases a woman's risk for lymphedema. BIDMC offers a lymphovenous bypass technique, which allows us to reduce the risk of lymphedema. Currently, that technology and the opportunity to do that is only available at BIDMC. So these are two instances where patients would go to the main campus. But outside of that, any other surgical intervention will be performed at BID Needham.
Thank you so much. I'm just cognizant of the time. I think with this discussion could go on quite a bit longer. One very quick question, which might be timely, is if you do not have a doctor that is part of the BI system, can you still call and have a mammogram at BID in Needham?
Absolutely. I think women have the option and the choice to go where they choose to go for their mammography. So I don't see there being any barriers to that.
Thank you so much. I'm going to have Tracy just put her email in the chat. If anybody has follow-up questions or anything that they would like to ask, we'll certainly accept those questions. I'll also put my email in the chat as well. I don't think I really introduced myself at the beginning because I assumed everybody knew me, but that was perhaps untrue. So I'm Samantha Trotman-Berman, not to be confused with Samantha Sherman, and I'm the incoming chair of the Board of Advisors. And I'm very much looking forward to having more speakers of the quality. I think you've set a very high bar, Dr. Pandya, but we'll hopefully have some other really great discussions. And thank you so much, Dr. Downey, for joining us and participating.
You're welcome.
And yeah, this was a wonderful discussion that we will hopefully continue. And again, please reach out with questions. We also have two fundraising opportunities. One this coming Saturday called Bar 3 for Breast Care, which is run by one of our advisors. And also there we go, excellent. And also Big Steps Toward Cancer Prevention race as well. That Dr. Downey is involved with. And so we would love participation with those because obviously this excellent care in our own backyard cannot happen without funding and donors from folks like ourselves. And so we'll get that information out. And if you have questions on that, obviously Tracy can also answer those. So with that, thank you very much for sharing this hour with us this morning. It was very enlightening, and as always with these types of events, we feel a sense of connection in the community, which is also incredibly important. So thank you very much, everybody. Have a wonderful rest of the day.
Thank you,
Thank you.
everyone.
Thank you for having me. Take
Bye.
care.
Thank you for having me.
Thank you.